Hey, Dr. Brogan. My name is Elizabeth Roberts, and today we're going to talk about two cases that are part of the Case Connection 4. Yay! We have a lot to cover, so I'm going to try to give you as much information as possible in about approximately 10 minutes or less, give or take 2 minutes. So we're going to talk about Case Connection 4. We're going to start with Case 3. I'm kind of going a little backwards here. So this is a 47-year-old man who presents with gout to the right great toe. He is unable to bear weight on this right toe, and there's no apparent trauma. So the pain started last night, and then it just got worse overnight. Based on his physical exam and laboratory findings, and the blood drawn, it shows that the patient had, you can see here, 10.5 in the plasma urate, and the normal is usually 7 or less. So it's just slightly elevated. And then the urinary uric acid was 215, and the normal is about 413, give or take 78. So 215 is on the lower end, so the patient is not excreting as much urine as a normal individual should. So if you see here 413, it says give or take, meaning you can probably add 78 to that number, or you can subtract 78 from that number. So if we wanted to subtract 78 from 413, you probably get somewhere around 330 some, which still leaves the patient excreting very much less than the normal levels. So after further discussion, he also tells you that he switched from diet soda to regular soda because they said that the diet soda had fake sugars. Now keep in mind, regular sodas have high levels of fructose, so just keep that in mind. So what is the basic explanation for the presentation of this individual? So we have three possible things: overproduction of purines, decreased salvage of purines, or underexcretion of uric acid through the urine. Also, we're going to talk about what are the potential impacts of this dietary modification on the presentation of gout, meaning what changes can be made from gout. So I forgot to set the timer. We're going to go here and we're going to start. So let's see. So what is gout? So high levels of uric acid in the bloodstream, the product of purine catabolism. So causes of hyperuricemia, that's uric acid in the bloodstream, can be caused by an overproduction or underexcretion of uric acid, meaning we're producing too much uric acid or we're not getting rid of enough uric acid. So what factors can increase hyperuricemia? Purines can be consumed two ways: endogenous, the body makes it, and then exogenous are purines that are taken from our diet, things that we eat. So seafood, steak, and other meats, along with alcoholic beverages and sugar drinks with fructose. What? Yes, sugar drinks with fructose, such as sodas, they can all increase hyperuricemia. So let's see. So gout causes these little nodules in your joints caused by that monosodium urate deposited in them. It mostly affects the toes and the big Brett Flintstone toe, and they are very tender. They get inflamed and swollen, just tender to the touch, very painful. So we're going to talk about the first one, overproduction of purines. So people say that you can't really tell if the body has an overproduction of purines. However, there are studies that have showed that overproduction of uric acid, which is probably an overproduction of purines, may be due to the increased availability of the PRPP. I'm going to try to pronounce this, 5-phosphoribosal 1 pyrophosphate. PRPP, so increased availability of this, increases purine production or purine production, which can result in elevated levels of plasma uric acid once they're they're broken down. So it mostly affects patients with myeloproliferative disorders, people receiving chemotherapy, or people that suffer from metabolic diseases such as von Berg's disease or hereditary fructose intolerance. Now, our patient does not suffer from any of that. So I don't think that the patient is overproducing purines. He is taking a lot of purines through his diet because of all that soda that he drinks, but that alone would not cause an overproduction of purines. And then decreased salvage of purines. I'm going to move this down just a little bit. You can see the title. Decreased salvage of purines. So let's see. What is salvage of purines? Purines that are not degraded from normal turnover of nucleic acids, meaning that purines can be converted. See, purines that are not needed anymore can be converted to nucleoside triphosphates. They can then be used by the body for other purposes. Now, two enzymes that are involved with the salvage of purines, that decrease is not supposed to be there. Just enzymes involved with salvage of purines includes the APRT, adenine phosphoribosol transferase, and the HGPRT, hypoxanthine guanine phosphoribosol transferase. These two help with the salvage of purines, however, that second one in orange can cause deficiency. The deficiency of HGPRT results in the Lesch-Nyhan syndrome. I'm not sure I'm pronouncing that right. So we're going to talk about that. So this syndrome is an X-linked recessive disorder. Complete deficiency of this enzyme decreases the ability to salvage hypoxanthine or guanine. So excessive amounts of uric acid are produced. So some of the things that can be seen with this syndrome include gout, uric acid stones in the kidneys, and neurological symptoms such as biting of the lips, biting of the nails, motor dysfunction, and other cognitive deficits. The patient in question does not suffer from neurological symptoms, and there's no indication that he has stones in the kidneys. There's been no diagnosis for that. Also, if you see over here to the left, down here, serum uric acid levels are 20 times higher compared to that of normal individuals. So uric acid in the plasma will show that it's significantly higher than within the normal limits. So we come back to our table. You can see our patient had 10.5 plasma urate, which is really not 20 times more than 7. So all this put together, our patient does not have decreased salvage of purines. Okay, on to the last one. So our patient probably suffers from decreased urinary excretion of uric acid. We did see that in our table. So again, our patient had levels of 215 compared to the normal, which is 413. So causes of hyperuricemia can be caused by overproduction or underexcretion. I would say that underexcretion of uric acid is definitely the culprit for our patient. He doesn't just consume sodas with fructose, he consumes a large amount of sodas. And on average, people drink maybe 2 or 3, not 2 or 3, but okay, myself. Sometimes I'll drink a 20 ounce, maybe it takes me about 2 weeks. I'll drink that much in 2 weeks. This patient drinks about 5 to 6 liters a day, which is the big bottle, and that's not good for you. So sugar drinks with fructose can definitely cause increased hyperuricemia. And of course, it's not able to be excreted sufficiently in the urine. So more than 90% of individuals suffer from this. It can be idiopathic, or it can be secondary to poor kidney function. Dietary modifications, too much regular soda. He needs to bring it down and not drink 4 to 5 liters a day. So he needs to either avoid fructose drinks completely or make dietary modifications to reduce exacerbation of gout, because now that he has gout, he really has to make those dietary modifications. Avoid foods that are rich in purine, as discussed earlier in the slides. Thank you so much. And that is the reference page. And a quick intermission here. Okay, and we're back. We're on case 2. We're going to talk about an infant who is thought to have thought to have an elevated level of phenylalanine, which was at 6.6 at birth compared to 1 to 2, which is the normal range. So a presumptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. The family denies history of PKU. As a consequence of this presentation, which amino acid may become essential? We're going to talk about what are the potential causes of the presentation of phenylketonuria. And then we're going to compare patient A to patient B, who were both given tablets of synthetic cofactor. And we're going to summarize the results for the test for patient A and patient B. So phenylketonuria, an inborn error of amino acid metabolism, inherited inability to metabolize phenylalanine, caused by a deficiency in the enzyme PAH. This enzyme requires tetrahydrobiopterin, BH4, as a cofactor or coenzyme, results in elevated concentrations of PHE, which is phenylalanine. Tyrosine is deficient. So these are some of these symptoms: mental retardation, convulsions, behavioral problems. Let's move this over. Okay, as a consequence of the presentation, which amino acid may become essential? Tyrosine. Tyrosine will definitely become essential. If you see here, this metabolic pathway here is a normal function of PAH. And then your PAH is an enzyme that turns this PHE into tyrosine. And with the deficiency in this PAH, it's not able to make that transformation. So in essence, tyrosine becomes essential for this baby. What are the potential causes of the presentation of phenylketonuria? We have classical, atypical, benign, and malign. Each one represents either a complete deficiency, partial deficiency, or even deficiencies with other enzymes that affect the BH4 cofactor. So how would you summarize the results of this patient? So both patients were given the BH4 administration. The BH4, again, is that cofactor, coenzyme needed to help make the PHE into tyrosine. So patient A, the PHE levels actually increased. So we would say that she probably has a deficiency in PAH. And then we're going to move over to patient B. So patient B, actually, her pH levels actually decreased. So it might indicate either a BH4 deficiency or a possible deficiency in the dihydropteridine reductase. This enzyme is responsible for regenerating BH4 from BH2. So with supplementation of BH4 and replacement therapy, the outcome of PKU can certainly improve, although the results are changeable or unpredictable.